Welcome to Webisode 7 on Reinstatements. I'm Eric Morse, an addiction psychiatrist with over 18 years of experience working in opioid treatment programs. In opioid treatment programs, OTPs, we talk about reinstatements versus readmissions. Patients in OTPs can miss a day once they've reached a stable dose, and they will not go into severe withdrawal. This is because their stores of methadone or buprenorphine with half-lives greater than 24 hours. If the patient misses a day and are not impaired due to a return of use, we can safely give them their stable dose without any other intervention. In North Carolina, when a patient misses 2 or 3 days and they come back into the OTP unimpaired, the OTP will usually half-dose the patient and then have them return to their stable dose the next day. If the patient misses 4 to 30 days and returns to the OTP, we reassess them, and a medical provider decides how to reinstate the patient. Missing more than 30 days is usually called a readmission and requires a completely new evaluation, consents for treatments, and starting over with a new induction order. So let's focus on reinstatements for patients who have missed 4 to 30 days of treatment. Obviously, we don't want any of our patients missing days. We would love to have 100% perfect attendance in all of our OTPs. That would be impossible for any human being to achieve. We want to retain our patients. The number one indicator for best outcome in OTPs is based on how long the patient has engaged in treatment. When they miss 4 to 30 days, we want to get them back into our OTP and get them back on their stable dose as safely and as quickly as possible. Step 1 is to meet with the patient and find out where they've been and what and how much opioids they've been using. If they've been in the hospital and have been dosing at their usual dose, they simply bring their records to us. We call and confirm them, then document everything and keep them on their stable dose. We still get a drug test to make sure that other drugs aren't on board. If they've been If they've had nothing in 4 days and are still in withdrawal, you may want to half dose them and go up 10 milligrams a day until they're back on their stable dose. If it has been 30 days with nothing, no withdrawals, you may want to discuss the option of naltrexone or buprenorphine first. Then if they decide to choose methadone, you may want to start low and go slow, like 10 milligrams with 5 milligram increases every 3 to 5 days. Maybe they won't need as high of a dose this time around. It's hard to know. It is the in-between that can be challenging. Missing 14 days with sporadic use. You're not sure about the tolerance level and where to start. 30 milligrams is usually safe, and going up 5 milligrams at a time every 2 to 3 days with follow-ups with medical providers until they get back on their stable dose is usually reasonable. I do not think a protocol per se can help with this. I think it has to be individualized with medical provider follow-up, similar to an initial induction. Getting more frequent drug tests, COWs, and more counseling visits can be very helpful in the reinstatement phase. Step 2 is problem solving to make sure missing days will not continue. You may need to figure out new transportation involving public transportation, Medicaid or low-cost vans, or your OTP's share a ride board can be helpful. Is there a medical or psychiatric condition that needs to be dealt with? Are domestic violence or child care issues involved? You may need to do an attendance contract with a patient, so clear expectations are made and followed. Step 3 might be to make certain that the OTP is the right treatment modality for the patient. Should we be looking at something more intense, like inpatient, residential, or sober living situation near the OTP? If it's somebody's work getting in the way and they were stable, should we be looking at OBOT or naltrexone in a doctor's office closer to them? We say we vote with our feet. When a patient misses days, it gives us the opportunity to take a step back and see if there's a better way to treat the patient's opioid use disorder. If you have further questions, please feel free to contact your state opioid treatment authority. Thank you for watching, and keep up the good work.